First, anatomy and risks. Second, pneumothorax. Third, empyema. Fourth, lung cancers. And we'll wrap it up with number 5, mediastinal tumors. Starting off with Section 1, anatomy and thoracic surgery risks.
Okay, let's start with a fundamental rule of the chest that has massive everyday clinical implications. The right main stem bronchus is noticeably shorter and straighter than the left. Plus, the right lung has 3 lobes while the left only has 2. So, why do we care? Well, it's basically gravity and anatomy working against us. If a patient aspirates or inhales a foreign body, it is preferentially going to go right. And post-aspiration, this almost always causes abscesses in 2 highly specific spots: the posterior segment of the upper lobe or the superior apical segment of the lower lobe on that right side. If you've got a patient with stridor, wheezing, or a collapsed lung right after a choking episode, this is absolutely where you look first.
Now, before we even think about opening a chest, we have to talk risk. We use something called the Thorex score to predict mortality. It's a really sharp 9-parameter tool that factors in things like the patient's ASA grade and their Zubred status, which is basically a measure of their daily functional ability. Opening the chest is a huge deal with real morbidity, so predicting that risk is crucial. But what about after the surgery? To predict postoperative dyspnea, we actually rely on 2 key pulmonary function tests: FEV1, that's forced expiratory volume in 1 second, and DLCO, the diffusion capacity of the lung.
Moving right along to Section 2, managing spontaneous pneumothorax.
Keep in mind, trauma and tension pneumothoraxes have their own separate trauma protocols. Here, we are strictly talking spontaneous emergencies, and there is a huge clinical difference between the 2 main types. Primary spontaneous pneumothorax happens in people with no underlying lung disease. We're talking fit, tall, thin young guys, often because an apical bleb just ruptures. Think of an airline pilot mid-flight. Because they're healthy, they actually tolerate it pretty well. It can even be self-limiting. But secondary spontaneous pneumothorax, that is a whole different beast. It happens in elderly patients who already have underlying lung disease, like TB, tumors, or emphysema. Their lungs are already compromised, so it's poorly tolerated and almost always requires stepping in with an aspiration or a chest tube placed right in the triangle of safety.
So what happens when conservative management fails? Or if that pilot we just mentioned needs to make absolutely sure this never happens again? We turn to VATS. That's video-assisted thoracoscopic surgery, and it is an absolute game changer. Unlike abdominal laparoscopy, we don't pump the chest full of air to see what we're doing. Instead, we use a double-lumen endotracheal tube. This is a brilliant workaround that lets us ventilate one lung while deliberately collapsing the operative lung. Bam, instant working space. It lets us get right in there, repair the air leaks, and snip out those dangerous blebs. And while we're already in there during VATS, surgeons will often do a procedure called pleurodesis. The goal here is to make sure the lung never collapses again. We actually go in and intentionally inflame the parietal pleura and visceral pleura using chemical irritants like talc or tetracycline. We want them to scar and fuse together. It is incredibly effective, but as you can probably imagine, notoriously terribly painful for the patient. So heavy, proactive analgesics are an absolute must here.
All right, Section 3, the 3 phases of empyema.
Empyema is basically a dangerous buildup of frank pus right in the pleural space. Usually it's the fallout from an unresolved pneumonia, trauma, or maybe a ruptured liver abscess. And it's a nightmare that escalates in 3 distinct phases. Phase 1 is the exudative phase. You've got thick pus driven by bugs like Staph aureus or strep. Simple aspiration and antibiotics actually work pretty well here. But if you miss it, you hit Phase 2. The fibrinopurulent phase. The pus and the pleura start getting thick and sticky, making aspiration super difficult. Finally, we hit the point of no return, Phase 3, the organized phase. At this point, the pleura has thickened so much it literally traps the lung like a concrete shell. It can't expand. Aspiration? Completely impossible. You have to go in surgically with VATS or do a full decortication just to peel that rigid pleura off and free the lung.
Now, here's a massive clinical pearl for you. Beware of loculi. If you look at a CT scan of an empyema, you'll see it's rarely just one big puddle of fluid. It walls itself off into multiple separate pockets, or loculi. So what does that mean for us? It means if you just blindly jam a single chest tube in there, you're probably only draining one pocket, while the infection keeps reaching everywhere else. You have to ensure all the loculi are drained, or that empyema is coming right back. Let's move to the heavy hitter, Section 4, unpacking lung cancers. Lung cancers are frankly one of the leading causes of cancer-related deaths globally, and as we know, they're heavily driven by environmental factors: smoking, asbestos, pollution. The truly tragic reality is that only about 20 to 25% of patients present early enough for us to even attempt a surgical resection. So with those tight margins, how exactly do we categorize these tumors to map out survival and decide on a treatment strategy?
Well, we basically split them into two very different camps. On the left side of the table, you've got small cell or oat cell lung cancers. These have the absolute strongest link to smoking. They're super aggressive, they carry a poor prognosis, but they are highly chemosensitive. They're also famous for causing paraneoplastic syndromes, think Cushing's, SIAD, Lambert-Eaton syndrome, and they can trigger superior vena cava syndrome. Now on the right side, we have non-small cell cancers. Within that, squamous cell carcinomas are usually central. They can cause hypercalcemia, and they can grow up in the apex as Pancoast tumors, which compress the brachial plexus and give you Forner syndrome. Then you have adenocarcinoma. This is typically peripheral, and it is actually the most common lung cancer overall right now, especially in non-smokers and women.
But wait, there is a fascinating exception you need to know about: bronchial alveolar carcinoma. This is an in situ lung cancer with a totally unique way of spreading. It moves in what's called a lipidic pattern, meaning it sort of crawls right along the lining of the bronchioles. And the crazy thing? Even though it pops up in multiple different spots, it's multifocal, it is still surgically resectable.
So how do we actually decide who gets that surgery? We strictly use the AJCC 8th edition T staging. Let's break down the T, or tumor size. T1 is under 3 centimeters. T2 is 3 to 5 centimeters. T3 jumps to 5 to 7 centimeters, or if the tumor is invading the chest wall. T4 is anything over 7 centimeters, or if it's aggressively invading the mediastinum or great vessels. Generally speaking, surgery is strictly reserved for patients who are T1 through T3, with N0 or N1 nodes and absolutely M0, no metastasis. To confirm all this, we rely heavily on PET-CT scans to check for systemic spread, and we use EBUS-FNA, endobronchial ultrasound with a needle, to biopsy those lymph nodes.
For that 20 to 25% of patients who are actually eligible, the classic surgical approach is the posterolateral thoracotomy, going right through the latissimus dorsi and serratus anterior. Depending on the tumor, we might do a conservative wedge or sleeve resection, or we might need to go all the way up to a lobectomy or even a full pneumonectomy, taking the entire lung. But surgery is rarely flying solo anymore. Today, we're pairing these physical resections with highly targeted therapies and immunotherapies, which are dictated by specific IHC markers on the tumor biopsy. Let's wrap up with Section 5, mediastinal and benign tumors.
Before we dive into the mediastinum itself, I want to quickly contrast two unique non-malignant lung conditions. First, the lung hamartoma. This is your most common benign lung tumor. Patients usually don't feel a thing. It just shows up incidentally on an X-ray as a classic coin lesion or with that famous popcorn calcification. Now contrast that with lung sequestration. This isn't a tumor at all. It's a congenital embryonic defect where a piece of lung tissue gets separated and actually draws an abnormal blood supply directly from the descending thoracic aorta instead of the normal pulmonary circulation. Okay, into the mediastinum. It is so helpful to mentally map these masses to their specific compartments. In the superior compartment, you're usually looking at retrosternal goiters. The anterior mediastinum, just remember your 3 T's: thymoma, terrible lymphoma, and teratoma. Drop down to the middle mediastinum, and it's all about cystic lesions, specifically the pericardial cyst. And finally, the posterior mediastinum. This is the domain of neurogenic tumors. And here's a pro tip. Posterior neurogenic tumors are the most common mediastinal tumors you will find in children.
Let's zoom in on the biggest player in that interior compartment, the thymoma. It is the most common mediastinal tumor overall, and we stage it using the Massaoka system. But here is the most fascinating part: its direct link to myasthenia gravis. For patients fighting myasthenia gravis who just aren't getting better with medication, surgically removing the thymus, a thymectomy, is a game changer. It provides a massive therapeutic benefit and can directly halt the progression of their neurological symptoms.
And to put a real face to this, remember that the anterior mediastinum is also the most common extragonadal site for germ cell tumors. Now, 75% of these are just benign teratomas, but the malignant ones will spike markers like alpha-fetoprotein, beta-HCG, and LDH. This is the exact condition famously battled and beaten by Indian cricket legend Yuvraj Singh, which was incredibly detected right in the middle of his World Cup run. So what is the ultimate takeaway from all this? Thoracic surgery is a high-stakes world defined by constant, rapid innovation. We've talked about the incredible precision of double-lumen VATS, the life-saving impact of targeted immunotherapy, and the complex staging of these tumors. The field is moving so fast, so how completely will the thoracic surgeon's playbook be rewritten by the time you're the one holding the scalpel? Keep that in the back of your mind as you review this explainer, because the rules of the game are literally being updated as we speak. Thanks for joining me on this one.